and ask a couple questions regarding some of these devices, because we talked about a lot of devices. Let's start with the first one. Let's imagine that you could only have one. If you could have one re-entry device, we heard about 4 today, I think, which one would you have? Pick one.
I think the one that I've got the most experience with is the Outback. I think it's been a very successful workhorse for most folks that have wanted to use it. The other thing is that, ultrasound or IVUS has its utility in the aortoiliac areas, but it really doesn't have as much utility in other places. And sometimes flow can be a little bit deceiving. It could be venous flow that you're seeing if you're looking at the SFA and otherwise. And I've been able to use the Outback in the aorta, the SFA, the tibial vessels, and even further. So if I had to pick one, that's probably what I'd pick.
And is the most cost-effective. Okay, Usama, now your turn. If you were to pick two wires for crossing the tibials, maybe one jacketed and one CTO, what would be your top choices?
I prefer the Regalia 014, 035 deep wire.
Which one?
Let's focus 035.
035.
Yes.
Now let's talk about that for a second, because there are some people in the audience here. I personally do not use 035 wires in the tibials. I don't know, Nick.
I think 035 is the most reliable for revascular. That's a CTO.
In the tibials.
TBR,
yeah.
Of course.
Nick, and what do you think? What are your thoughts about 035 in the tibials, as Osama showed us?
It's obviously it works. The thing is, I usually use the either 014 or 018. I mean, that's typically my approach.
How about you, Peter? What do you use for the tibials typically?
I start with nitrix 014s coming down. If there's microchannels, I use Fielder XTs. I'll actually use that end-tier wire free through an 018 microcatheter to re-enter if I have to. So free of the balloon and just re-enter with the wire
usually
itself.
014, 018 systems.
All 014 systems. Coming retrograde, I'll use 018s, but...
How about you, Ramon? I know you said it, but say it one more time. For the tibials, what is your choice of wires?
Well, I'll start off routinely with an 018 wire, usually either a V18 controller or a Command 18. Yeah. But as soon as I've crossed, then I go to an 014 platform for the low-profile nature of the balloons. And I'll use occasionally 014 CTO wires if I hit a really tough cap.
So the next question is in regards to retrograde access. A few of the operators here mentioned that they only go to retrograde after they have assessed the situation or they have tried antegrade. What is your algorithm? Is it based on wires? Is it based on time? We use time, as I mentioned. But do you have an algorithm as to when do you say, okay, I've tried enough antegrade, now I want to go retrograde? Let's start with you again, if you don't mind.
Yeah, so I think the key is not to make an ad hoc procedure. So when you see a long segment occlusion and there's calcification and there's a decent distal target, sometimes they're not perfect, but at least they're there. I prep the whole leg. You make sure you've got the ability to get to that access site. And you have a pretty good sense of if the procedure's progressing. And if in 10 to 15 minutes you're not seeing progress, then I go retrograde quickly. But I think the point is that I'll stay longer on the antegrade approach if I'm seeing obvious progressive movement in the right direction and I know that I'm very close to re-entering. I'll stay antegrade, but I won't stay there long if I know that I've already failed in that territory.
Anything to add to that, panel?
Just in general, for algorithmically, prepping the foot, every CLI patient, the foot gets prepped. Every patient with a long, SFA or popliteal CTO that we're worried about, antegrade process, we prep the foot. With regards to use of CTO devices, kind of buried inside of the algorithmic crossing for CTO is also this concept of those first 5 components, someone with CLI with a long occlusion with a blunt cap. I'll honestly say if there's a blunt cap and a long occlusion in someone with claudication, I'll sometimes use a CTO crossing device initially there. Not that you can't safely re-enter a tibiopedal, but all the CTO devices are designed so that if they're used initially prior to wire dissection, they work better. And if I see a blunt cap and a long SFA occlusion in someone with claudication, I'll sometimes use a Viance as my primary strategy to cross.
And Nick, one question, one of the things that I have experienced is that in a lot of these long CTOs, you need multiple wires. You may use a CTO wire to enter the cap, then you may go to a jacketed wire loop, then you may use another CTO wire to re-enter, the tips get damaged. Just for the audience, I just want to give them a sense, because sometimes I use 10 wires. So what do you think is the average number of wires, and I know I'm asking tough questions, for crossing a CTO TBL vessel?
Well, you could use easily 3 to 4 wires. I'm sure you're using 10 wires, but the point is, you really don't need to start with a low gram wire all the time. If you look at your lesion and you look a lot of calcification, long lesion, I tend to start with a higher gram wire. I tend, go straight to a 25 gram approach, for instance. And if I cannot do it, I'll maybe go to an Astato 30 or even 40. So I tend to be more aggressive right from the beginning, rather than play around with the wires too much and end up spending 10 wires, because that can happen easily.
Thomas, please.
Coursera or a Turnpike LP to cross these tibial lesions antegrade, and I found them to be very successful in the terms of some of these stiffer CTO wires get subintimal very quickly and easily in the tibials, whereas a Turnpike LP, you set it out there and you spin it across and it deflects off. Very difficult to get subintimal or perforate with the microcatheter. That's one thing I've observed. Secondly, Dr. Leto, what 035 wire are you knuckling in the tibials? That's another thing that I've not seen, very, very curious about. What type of 035 wire are you knuckling?
Telumo 035 1.5 J-tip wire, stiff one.
Yeah, so it's called a stiff 035 Telumo J wire.
Okay, thank you.
I think he has some in his bag, we can borrow from, But
has
the
anyone
one
on the
question I want to ask you, Thomas.
Yes.
When you're using the microcatheter, do you have a wire inside at the tip, or just the catheter?
Just behind the tip, but you're spinning it bareback.
Right,
There's no wire across.
That's
and
right.
I would say, and this is from experience, probably 49 out of 50 times it crosses. Right. I used to use an 035 straight stiff glide wire to penetrate, but the microcatheters are very safe, and again, they don't get subintimal, and they don't usually perf, very uncommon.
Okay, yeah, well, thank you so much. I appreciate your comments, and I think that we left the best for last. This is my favorite talk, and I've heard it many times, and Tony does such a fantastic job on this, and I know we have a lot of young junior faculty and fellows in the audience. So this is from fellowship to real world, step-by-step guide on how to be successful and build a vascular practice. Thanks, Tony, for doing this.
You're so welcome. Again, we have such an experienced group of people. This is an irrelevant talk for these guys, but I will say there's a lot of things that you're going to nod your head on and then say that, yep, that makes a lot of sense. So I've been asked to give this talk about how to develop a practice and how to be successful. So let's just kind of get to it. I think there's probably 5 steps in your career, and they occur over the period of fellowship all the way to when you get gray hair like I have. First is the honeymoon phase. We're familiar with this, and I'll tell you a little bit more about that. The second is just developing your reputation, and there's multiple levels of what that really means. There's a lot of communication, working with, consulting for, developing with industry, and I think that's an important part that you need to be able to incorporate. There's a lot of new technology, and adopting that into your practices is important. And then ultimately there is this whole stage of reinvention. Everybody knows about the honeymoon phase. You get out of your fellowship, you get into practice, and you use the 3 A's. One, you're nice to everybody, you're available all the time, and people just assume you have ability, so that kind of comes later. Affability is basically being nice to everyone in the sense of that your personality is the majority of your referral ability. Being nice means to everyone, not managing up, but basically talking to everyone, including the folks that are cleaning the floors. I one time got a referral from a patient because they heard me talking to a family member, and they said, "You seem very nice," and this is the lady that cleans the hospital floor, so I take care of a lot of those people. There's really no great way of winning back referral doctors if you kind of blow it at the beginning. So what does it mean to be available? One is just be around. So I used to go through the emergency room every morning when I first started in practice, and they'd say, "Oh, I've got a referral from you from last night." At this stage, you don't really care about whether people are covered, insured, or not. They just want to get to you. The second stage is really developing your reputation. So you can make some bad choices, which is probably not a good idea, but your reputation is both with your peers, professional reputation, with administration, and the hospital committees and your ability to be incorporated in being one of them and not one of us. In that situation, I think it's very important because you get a lot of latitude that way, and then through the community. You didn't really learn how to give really good service in fellowship because all you're really doing is running from one case to the next. So the ultimate thing is to be a good provider for your referral doctors. Providing good service means taking problems off other people's plates. So when someone calls you and says, I got a referral for you, and it's even not something that you do, just get it off their plate and put it on somebody else's, because that's what they're looking for. You need to talk to doctors that want to learn, and doctors that are kind of stuck in what they do and they always do it one way. They're probably not great referral sources for early adopters. Understand what their goals are and you can help them, bringing value to their practices as well. And don't assume that people know that you have either the best skills or even the best knowledge. You're going to have to continue to show that to people, but not by selling yourself, but more by really letting people learn about your reputation. And your peers need to understand this as well. I mean, it's my bad. Sometimes I got people after 20 years in practice say, you do peripherals? And I say, I obviously haven't taught you very well. You got to present at grand rounds. You've got to go to dinner talks. You've got to do these things and becoming the local expert in something. And that's a really broad term, and I'm going to get back to that in a minute, because ultimately, if you're identified as an early adopter, people will continue to look to you for things that are new and different. Early adoption doesn't mean being a renegade about things, but as new devices and new techniques come out, understand the data and understand the indications and be part of the educational process for these. And there's a long history of experts in this cardiovascular and vascular field that you keep seeing the same people adopting new technologies and being early adopters. The community needs to understand what you're doing as well. So you need to educate yourself, know the data backwards and forwards, and that's going to be your biggest armor. In addition to that, educate your referring doctors. They don't know what's new. You live and breathe structural heart and vascular and coronary disease, and you can recite backwards and forwards all the data, but they don't know the first thing from this other than what they read in USA Today sometimes. Capitalize sometimes on those high-profile patients and get out there and really put yourself out there. And your hospital will want to promote leaders and folks that are out there doing new devices as well, because for the hospital and the hospital systems, this is an advantage for them in a very competitive field. Organize conferences. I organized in 2001 the first Cutting Edge conference, and that was a conference that we did in Dallas, had about 300 people show up in the second year of that conference, and that actually melted into VIVA, which is now a national conference for vascular disease, just like the guys that have organized this meeting have done. I think that when you put together conferences, you definitely are an early adopter and are educating, which means you've got to learn yourself pretty significantly. This is something to avoid. What is this? What is this? This is putting your foot in your mouth. This is a bad thing to do during your transition from fellowship into practice, and it includes stupid things like criticizing other physicians, because it always gets back to you. There's no reason to do that. Taking things out on your patients, like if your charts are lost or if you're post-call and tired, you just can't do that. The most important thing I can teach you is to have professional honesty. And so even very complicated things, if you don't have the experience for it, wait. We just saw Dr. Aida show us how to take an 035 wire down a tibial vessel. So if you run home and you start doing this and you have a bunch of compartment symptoms and complications, then you're going to be probably scrutinized for that. So be upfront about your experience, educate people about what you're doing, and you'll do fine. One more case isn't the goal. It's a long process. The third part is kind of a tricky one, because there's a little bit that's important with industry relationships about getting to know the regional and national leaders, but it's a two-way street, right? They're looking for folks to enroll in research trials. They want to make sure that you're organized. I would keep a list of all my patients in my phone and have that available so I know what types of cases and how many we've done over the years. And as new technology starts to grow, create the infrastructure or be attached to the infrastructure for being part of trials, being part of registries like the XLPAD, et cetera, because early adoption requires being part of the research portions of the development of these things. And ultimately, the last thing is to reinvent yourself. And this is part of the vision stage. After you've done a lot of the reputation building and early adoption, you've got to start creating plans, whether they're 1 year or 5 year or even longer, and identify where this is going. In my world, I think this is digital and the innovation that's happening in the whole remote monitoring world, because I think that's where this field is going to be going. Being creative in how to understand those new fields, I think, is really important. One of the things I think is really fascinating is if you look at the early adoption of technology, you see a lot of the same faces. So there's a couple of folks that you see on this list that I think are masters of this. They're very early adopters. You see Bill O'Neill, you see Nick Hopkins and Mike Dake. These are folks who I feel like you should probably emulate. And one is they stay involved in clinical research their entire career. They've been lifelong learners. They've stretched themselves every year. So I would always encourage you to try to put yourself in uncomfortable positions, because it's the only way that you're going to get better at things, and avoid being overly immersed in single technologies. So finally, I think that don't confuse yourself by being busy as being successful, because honestly, you can waste a lot of time. Stay and take the time to get educationally ahead, learn the process, whether it's at your hospital or otherwise. Prepare for these challenges, because you will see pushback and jealousy. And just remember, practice is a marathon. It's not a sprint. So with that, I bid you good luck with all your endeavors in the future. Thank you.